I thought if OCT is not probably can help us, why not we look into the retinal vascular index? So it's 7 minutes for me. Okay. So just we go back into the background of how all these things started. I think early 1800, 1900, ophthalmoscopy was invented, and that's where people started realizing the value of fundus photography, and then the fundus photographs were invented. But why these fundus photographs was invented to understand and appreciate the actual changes which happens, there were a few brilliant scientists who thought, why not they look into the retinal vasculature, which are not that visible to the human eye, and they started working out on algorithms to say what is the diameter of the artery, what is the diameter of the vessel or the vein, and then some people also went on and described the artery-venous ratio. I don't know how this thought was conceived, but this one was a very novel discovery done by a lot of people, and we just this morning itself we received the proof of in Survey of Ophthalmology about acceptance of this article, and we were just reviewing it. But in that review of literature, we managed to see that this caliber or this particular index has been applied in various systemic diseases and also the ocular diseases, wherein they have shown the structural changes in the microvasculature and which is linked to these findings in the eye. So that really goes on to say that the eyes can be the windows to the health and the disease of a particular individual. A beautiful, amazing paper by Alex, dear friend sitting there with his group, and Anirudh Agarwal. I hope they are inside after their coffee break. And they published a very good paper and looking into the uveitis, and they just came up recently, and where they screened 89 eyes of 70 patients with uveitis, and the diameter of both retinal arteries was increased in the inflamed eye, and the dilatation was reduced when the eyes were quiet and after a prolonged period of time. So this was a very interesting finding, and that also was going on concurrently with the question which we had in mind. And the question which we had in mind was the similar question, that how does the vein and the artery diameters get influenced? What are the differences in the vein and the artery diameter between the active and the inactive phase of the disease with uveitis, and what actually leads to these changes, and also whether there is any focal changes. So with that question in mind, we designed this software, which took us some time, and it was initially designed on 45-degree fundus photograph, but when the sclerus or the wide angle imaging was coming in, we customized our software to also capture this information. So the first paper was published during the time of COVID pandemic, wherein we looked into the microvasculature in the patients with the COVID. But then we started looking into papers with Dr. Vishali Gupta and Atul, who is sitting here, into systemic hypertension, BRVO, but at the same time we were also looking into the patients with the uveitis. So these are the patients recruited from my clinic, and using this imaging machine of Zeiss Claris 500, and the patients with active uveitis were included, and also as a control group, healthy control patients were included. The patients with other possible potential known confounders were excluded. Why do I say that? Because I do know that, and I'm sure my dear friend Alex will agree with me, there are other 101 confounders which can affect, which include smoking, time of the disease, obesity, 101, but some of the confounders you just can't eliminate. So whatever confounders which you can eliminate, we try to eliminate during the time of exclusion criteria. The images were then processed and the results were extracted. Now the time will not permit for us to see that, but what we did novelty in this is using the ETDRS grid, which we either placed it on the macula or you can place it on the disc. We segmented the vessels into different segments and different zones, and we accordingly named that a new nomenclature we proposed here, so that we can identify a focal change at a particular point, not just the mean change in the AVR. So that is something which differentiates from the pre-existing other softwares, because it can give you exact area of focal ischemia if at all there is something happening, an indirect indicator. So using some of the statistical techniques, which we are not going to go into detail of it, we try to analyze the data. Again, this data is a preliminary data, not the final, and there were mixed bag of different types of uveitis patient, including posterior uveitis patient. So the results, the control versus the uveitis, of course there was a change, and this change was that there was changes in the AV ratio, as well as there was a change in the artery diameter and the venous diameter, wherein we can clearly say that the red area is the decrease, in the purple area there was an increase in this thing, and we were able to say that which part of the eye or which segment of the vessel was decreased. So the graph on the left side, which will tell you which particular segment has a significant change with a statistical value, statistically significant value. Again, we wanted to differentiate between the inactive type of uveitis and the active uveitis. Again, we were able to differentiate that mean 37R. What does it mean by 37R? Here is at the 3 month, and then the zone 7, the grid which is 7 disc diameter away from the disc was the vessel which was affected, and the AV ratio in that area was affected, and mainly because of the vein was affected in that. So there was a reduction in the venular diameter, and therefore the AV ratio changed. So we were able to demonstrate between the inactive and the active, and we were able to think about which vessel get affected and how it get affected. Again, there are so many parameters. You need to do some kind of a novel statistical technique to see whether these are really telling you the truth. Therefore, we run, and this is all work done by William, who presented all this work at UCLA meeting, which had been organized. And I was trying to get some tutorial from him how to read these plots, but he was busy yesterday and he could not give me the tutorial. Therefore, I'll try and understand, and whatever makes sense, William, you can correct me if I'm wrong. A particular variable, mean 37V, which is the venular diameter was affected, and which shows a AUC which is a little bit better, and a mean venular diameter was affected, which also shows a better AUC, but not the best, because typically you want to look into the AUC of 0.080 and above. Also wanted to compare between the baseline versus the follow-up, so we could see that there are some changes between the baseline and the follow-up. So in the interest of the time, and also because of my, this will probably take some time even for me to explain how these plots can be read between the active and the inactive and all. So the time can probably, we can go into the detail after this talk, and if someone is interested, and we can really go into that. But again, to conclude, and based on this preliminary data, there were differences observed between the healthy control and the uveitis patients for the AV ratio, primarily due to decreased artery diameter and increased venular diameter in uveitis patient. Our finding partially confirms the report from Invernessi's paper, while we observed a reduction in vein diameter between baseline follow-up in patient achieving remission. In addition, we also found increase in the artery diameter and AV ratio, contrasting poor prior findings. The delta, which is between the baseline and the follow-up in certain areas, demonstrated, and certain areas, the areas which I told about _7, was the area which demonstrated high sensitivity with almost near 0.7 accuracy, is objectively able to determine inflammation improvement. With that, I'd like to thank my team for putting in the efforts, and it's all the team efforts which the team Proton has been putting up. Thank you very much.
Thank you very much. So we have time for a question. Anyone from the audience with a question? No? Okay, I have a question. So a lot of our patients today have diabetes, and I know that was an exclusion. Do you guys have any plans to look at the effect of comorbidities in this? Because that would be really helpful as well.
Yeah, so that's definitely one of the plan, and rather I started this project as a very ambitious project with a retinal health index, which will develop in even the normal and little bit between abnormal and the disease population and all, but actually very, very ambitious to include all those patients, remove the effect of the confounding factors and all, because there are definitely, and we definitely want to look into that, and hopefully in future maybe that's the plan. But before that, we really want to validate some of the softwares, and so that it is performing properly. And once we can do that, and we know that it is not because of the software error, it is because of the real change, then we can try and implement. Because if we try to go for it, now it will be confusing whether it is the real change. Thank you.
Thank you very much.